tried to adapt my presentation to people outside the health sector, which has been somewhat difficult because in some ways I am saying that there's some things special about each sector that require a specific way of managing and leading services. So while there is some overlap, maybe there isn't in other areas. This is an exploratory study, so I haven't evaluated intervention, but I'm really doing these raising some questions around how does one manage the transformation within science facilities, acknowledging that community empowerment is very essential to push that change. But are there levers inside a facility one can use to change the way the public sector works? And I'm also challenging myself. I've done research for 20 years, and I think I made mistakes in those 20 years. And this is part of my process of trying to see whether I can rethink some of my assumptions of the past. So how is this relevant to the broader themes of the conference? Part of what we're doing over these 2 days is thinking about ways to strengthen the public sector whilst acknowledging that it has failings. And so the second point of relevance here is how does one transform the public sector? How do you strengthen it? How do you change the way it does its business? Especially in this study, the way it interacts with citizens in terms of providing quality of care and responsive services. And secondly, the way it interacts with its own employees. How I can draw on the tacit knowledge of frontline staff, but also create better working environments for employees. And I want to challenge some trends which I think are emerging over 20 years of reform in the health sector. I think in an effort to try to fix all the many things that are wrong with the public health sector, there's increasing bureaucratization, more memos, more rules, an attempt to impose from the top order on what's public health system. And I don't think this is always good for the system. I think also there's a tendency to import ideas of how to be better managers from the business school environment without tailoring that to the public sector ethos. And so there's an elevation of the importance of efficiency, financial prudence, etc., over some of the core issues that health services deal with, which is providing care. I think there's been a focus on management, which is really about how you stabilize a system and daily make it work properly, at the expense of looking at the long-term vision and leadership that drives it forward. I think that we're still stuck in a mechanism of promoting people who've been there for a long time into higher positions, rather than matching people with skills to the right jobs. And I think this has really harmed leadership in the public sector generally. We're also stuck in a system where if you want to advance in the hierarchy, you have to leave what you're good at. If you're a good practitioner, if you're a good clinician, you've got to leave that post and move into management away from service. I think there's also a way of, there's sort of a pattern of devaluing the skill and knowledge that health workers have because they behave badly in the hospital in terms of protecting their own interests and abusive behavior towards patients, that we throw the baby out with the bathwater and devalue what they have as special in terms of offering guidance around clinical care. And it's actually difficult, I think, at this point in time to talk about elites such as doctors and try to motivate for strengthening of their role in the health system. This doesn't fit in with the politics of the moment. And lastly, I think that because if you analyse the problems of the health sector now and you compare it to the analysis 20 years ago, it's very much a similar analysis, except that there has been progress on reallocating resources in broad terms between provinces, I would say. But many of the nitty-gritty problems at the local level remain the same. And I think that reflects part of the entry point for change. There's too much to do at once, and we're trying to do it all at once and haven't targeted levers sufficiently well. So before I go on to my ideas, I want to acknowledge the people who contributed ideas to the study and the funders who are MSP. But I also want to pay special tribute to the Chris Hani Baragwana Transformation Project. I don't know if any of you know of it. Anybody know? They're the people who made me shift my thinking. I had to evaluate this project under very difficult conditions in the hospital. And these people are listed here: Carl van Holt, Martin Smith, Alonso Mahaba, Colin Eisenstein, I think achieved a remarkable change within Baragwana for a while. And what's interesting about them is that if you look at where they came from, Carl van Holt is a trade unionist, an academic. Martin Smith is a specialist surgeon of international standing. Lonto was a trade unionist from Nauru, and Colin Eisenstein was a healthcare manager from the mining services. So you've got the a strange alliance here between academia, trade unions, and the private sector, and professional, who did really interesting things because they were able to break down barriers between their past experiences and learning. Just for those who are not in the health sector, just to note that when I talk about clinical staff, I'm not talking about clinicians or doctor clinicians. I'm talking about anybody whose job is daily interaction with patients, deciding, diagnosing their problems, treating them. So that's doctors, nurses, occupational therapists, clinical associates, etc. And why they're relevant is that they should fit into a new concept of clinical governance, which is a whole system of how you make sure clinical care is done properly in a system. And I think the way the term is used at the moment is too narrow. I prefer this wider definition, which is the creation of an integrated system for leading, managing, and monitoring the clinical process that promotes a productive culture in which clinical excellence can thrive, whilst also ensuring transparency and accountability on behalf of leaders, managers, and clinicians. So I don't think there is much clinical governance at the moment, and I'm asking the question of whether clinical staff can help to prompt it from the bottom. So for me, clinical leadership, the topic of the talk, is about the transformational leadership that clinical staff can bring to the health system. So why am I looking at clinical leadership as opposed to other things? We agree that I think we need strong public provision in order to achieve social objectives. Yet the public sector has very poor quality of care and such low morale that its very sustainability is threatened. At the same time, in these chaotic services, we do find committed individuals and good practice sites that seem to cope despite a lack of resources and lack of strong management from hospital CEOs. And I'm asking the question, could this be because in that hospital there are some clinical staff who are managing to move mountains? And that question came out of reading literature by Lipsky and Winsberg. Lipsky talked about street-level bureaucrats, and Winsberg talked about professional bureaucracies. That in fact, in a place like the health sector, the people who really make change happen are the frontline staff. Managers actually have very little power to change the way things are done, because the frontline staff have a huge amount of authority which they draw from their knowledge and from their networking with other health professionals, rather than from their formal status in the management hierarchy. And secondly, health systems are so complex, and the patient who comes in is a complex system in themselves, that you can only make decisions at that level. You can't really, at a high level, make good decisions around the quality of care. And lastly, because clinical staff are in fact, especially doctors, it's very strong in the training of doctors, that they are accountable to patients, and they're accountable to their profession. And in fact, they can be legally charged with malpractice. So they are the ones actually who are held accountable in the absence of public systems which are politically accountable to communities or to representatives. And they are actually the few people that are directly accountable. Of course, we know that many of them betray that accountability and abuse staff, etc. But at core, they have that potential, I suppose, to be directly accountable. So I'm asking here is that by facilitating the participation of clinical leaders in the facility's decision-making process, could one improve the responsiveness and quality and even efficiency of care? Could you improve their experience in the workplace and therefore retain them more easily? And by using that as a strategy right now, could you help keep services afloat while you try to implement more broad-scale reforms? And I should mention here that there are some district hospitals, for example, where you might only have 1 or 2 doctors. The facility might not be able to provide basic services like cesareans, for example. And there are hospitals that really are in dire straits at the moment, despite the fact that we're in a upper middle-income country. Why have I chosen district hospitals? They're not often researched. I think they're a very neglected part of the health system, of the district health system. The district health system is the core of the government's health policy. Yet in efforts to strengthen primary health care, which are very valid, I think district hospitals have been left off the agenda. They're also a critical site if you want to extend hospital coverage to the whole population under a universal health coverage policy. District hospitals will be the site delivering hospital care. They're often in rural areas, which we know are very disadvantaged already. And I'll speak later of the fact that they have features special features, unlike other high-level hospitals, which could support transformative leadership. And I think in any case that we well accept clinical leadership in clinics, that most clinics are run by nurses who are practicing and we accept that they're vital role in running the facility, but not so in hospitals. This is based on a qualitative exploratory project and it involves 70 interviews. So it's really not a big study. But one of the things I think that the work helped to do was to show that clinical staff are not just there treating individual patients. That's the stereotype. They do a huge amount of leadership and management in the health system. And that can extend to working outside of clinical care altogether. Doctors, senior doctors in hospitals, often they're senior in status, but they're actually might only have 1 or 2 years experience. So in fact, the ones who recruit new clinical staff, doctors, into the hospital often and drive daily the recruitment process because of the absence of human resource management systems. And they often solve things like leaking sewage pipes, etc. So they do a huge amount of work. We shouldn't typecast them as simply treating patients. In hospitals where there is good clinical leadership, or where you've got successful hospitals coping despite poor resources, these are the sort of lists of things that are happening there. They prioritise patient care over bureaucratic needs like filling out forms. They are hierarchical, non-rule governed organisations. They use collaborative, persuasive methods rather than control and command approaches. There's distributed leadership that many people in the organisation take responsibility, sometimes informally, for leading. They create microsystems of leadership and clinical care. And the managers and clinic clinicians are able to cross over. They can see one another's perspectives. And hospital managers see themselves as facilitating and engendering innovation within the organisation rather than running it themselves. And there is some information from overseas, from the UK and Australia mainly, that these sorts of organisations in fact result in better health outcomes. Another big finding, apart from those, is that, and I think this is I've highlighted this because it's different from what people are saying in the public sector here generally. So if you're a clinical leader, even if you're the head of all the clinical staff in your hospital, whether they be nurses or doctors, you must still do clinical work. Now, people in very big hospitals contest this, they say it's impossible. But all the people I spoke to, all the literature I read said, to be a clinical leader, you've got to do clinical work. As soon as you cross over exclusively into management, you lose those unique abilities that make you a leader in the organisation, because by doing the clinical work, you remember to keep patient care part of the organisation. It keeps you understanding the myriad of health system problems that affect the quality of care. It preserves the credibility, crucially, with staff, clinical and non-clinical, that people respect you for what you can do clinically. And it's crucial for understanding the way to manage your staff. And I found this quote extremely touching. This is from a very senior, experienced doctor in a district hospital. If you're still practicing, you have a degree of sympathy for the frailty of humanity. You understand under certain conditions that people don't always achieve their best, and that it doesn't necessarily mean that they're useless. And I think this points to the fact that blaming and victimizing health personnel for the failings of the health system is not the right way to go, so that they too are embedded in structural complexity. And that a good manager is not like a CEO of a car manufacturing company. You know, a good hospital CEO or a good hospital leader is somebody who can work with this imperfect scenario and draw the best out of people. So some challenges, or many challenges, remain to supporting clinical leadership. I'm not going to go through all of them, but a lot of it has to do with the fact that provincial and district managers burden leaders at the hospital level, facility level, with a whole lot of unnecessary stuff that stops them doing their jobs properly. And so I can ask why. It's partly because of the capacity problems at higher levels, a worry that at lower levels there isn't enough capacity to take on this responsibility. But there are also big power issues going on between different professions, and between managers and professions, and between spheres of government. One shouldn't deny that there are silos, that professions behave badly often in relation to one another. But I think the point here is that there are good people within clinical staff that should be cherry-picked out to become leaders. And one shouldn't forget that, of course, you need a critical mass to get anywhere at all. The same person who's quoted earlier said, despite him and his hospital being held up as huge success stories, in fact, his daily experience is a feeling of almost total collapse of the systems in the hospital because there isn't a critical mass of staff. So my final recommendations really are saying that at all levels of the health system, one needs to encourage clinical leadership and promote it. And And there are different ways of doing this, and I don't need to go into the detail. But I'll mention the very last point is that one has to grow new generations of leaders as well. Mustn't forget about that. And this involves transforming the way health workers are educated as undergraduates, but also how they mentor as postgraduates. And I think management training modules are not the solution. I think on-the-job, long-term sustained reflection and support is required. And I mentioned the management modules because there's now a management academy that's being set up in South Africa. I don't know if it'll achieve enough. So in conclusion, I think clinical leadership is essential for improving the quality of care, but also the wider efficiency. Often clinicians drive a change in efficiency, surprisingly. And also in balancing more top-down reforms like new management systems or norms and standards. I think those need to be balanced by an organic freeing up of potential at the district level. I think district hospitals are a good site for experimenting with this because of their strategic relevance, which I mentioned. They're very small, so these traditional silos don't really exist. People tend to work as teams anyway. In rural settings, the staff live on the property, and therefore this reinforces the interaction between different categories. And also clinical work is less differentiated, so there aren't really hierarchies. Each doctor does the same load of work, and each nurse does the same load of work. And lastly, what I would love to have done in the study but couldn't do is look at the role of unions improving the quality of care within hospitals, not just mobilization from outside, but how inside they can also, like clinical staff, contribute to improving